So we're going to have some questions here so everybody can poll.
Okay, let me know if you're seeing this.
I can see it. So a 71-year-old male reports increasing instances of misplaced keys. His wife confirms that she periodically has to help him find the keys. He works as a hospital volunteer and has not had problems with other ADLs. Your clinical impression is, firstly, mood disorder, early dementia, amnestic mild cognitive impairment, non-amnestic mild cognitive impairment. So if you could please put in your answers. Okay, so do we have a good number here?
There you go.
Yeah, so somewhat of a distribution. So he's forgetful, and I think this probably would represent an amnestic mild cognitive impairment. The non-amnestic mild cognitive impairment we'll talk about, but that basically is things like having problems with mathematics, adding up your bill, numbers, maybe some spatial problems, so having problems with three-dimensional configurations. So anything that involves forgetfulness would be considered amnestic mild cognitive impairment. Okay, let's have the next one. Very good. A quickie here. The greatest risk factor for mild cognitive impairment is age, sedentary lifestyle, smoking, opioids. So please submit your answer to that. And Julie, if you can put up our poll here. Yeah, so I think the bulk of people understand that all of these, quite honestly, are risk factors, but age is probably the strongest risk factor for any of these. So it would be true, as we will see, that sedentary lifestyle and metabolic syndrome and obesity actually is a precursor to, or can be a precursor to mild cognitive impairment. Opioids over long term can also contribute to cognitive impairments. Interestingly, nicotine has been used as a possible enhancer of cognitive function, but long-term smoking use is also a risk for cognitive impairment. Okay, so let's go to the third question. Very good. An 84-year-old female thinks her bank account was raided. She provided info over the phone about her Social Security check. She tried to call her son, who takes care of her finances, but he is traveling. She stopped driving a few years ago due to an accident. So your diagnosis here would be mood disturbance, Alzheimer's dementia, amnestic mild cognitive impairment, or non-amnestic mild cognitive impairment. So go ahead and submit your answers. I always like answering my own questions because then if I get them wrong, I have to scratch my head and figure out why I got it wrong. All right, so yeah, we've got a pretty good distribution here. In this case, I think this represents more Alzheimer's dementia, and we'll talk about why. But just basically to say that she's got global executive function problems, right? She's got a problem with somebody messing with her bank account. And then we already know then her family takes care of her finances, and she had to stop driving. A lot of these are, due to an accident. So these are all indicators that there's global loss of executive function. And we'll talk a little bit about what kind of tests that we can do to define loss of executive function. And also just to point out that she does have a deficit in her instrumental activities of daily living. So one of the key points that we want to make is that if you have mild cognitive impairment, you generally do not have a deficit or a problem with your activities of daily living, whether they're ADL or IADL. So key to this is that she's having problems with her finances. That's indicative of a disability or a problem with her instrumental activity of daily living. So therefore, that is more likely to suggest that she has dementia. Okay, so why don't we go to the first slide? Very good, thank you for answering those questions. We want to move up a little bit on the slide deck here. Go to the first slide. Yeah, so just as a reminder, we're talking about the geriatric 4 M's, and so this one is focused on mentation and specifically on mild cognitive impairment. Next slide.
I don't mean to interrupt. I apologize. Are you seeing the full screen slide again?
For me, I'm seeing the split slides.
Okay. There we go. How is that?
Now I can see the full slide. Thank
Okay,
you.
sorry about that.
Okay, that's all right. We can move on from our Jackson Pollock. And so we would like to define mild cognitive impairment. Today we also want to talk about the epidemiology. What are the risks? How do we diagnose MCI and how do we treat it? Okay, next slide. So there are 4 elements. It's basically mild cognitive impairment is a syndrome, right? So it's involves the subjective sense that I'm having problems either remembering things or doing things. It's also defined by objective cognitive determinants in at least one, maybe more domains of cognition. And again, we always have to remember that memory is only one domain. It could be language issues, as we saw with President Reagan when he was having problems finding words. He would always skip words or find problems searching for words. And then the key point that we made in our questions is that there's preservation of the functional status. So ADL and instrumental ADLs are intact, and that there is no dementia. So therefore, no loss of executive function, which is the primary diagnosis for dementia. Next slide, please. So in terms of epidemiology, the subjective cognitive impairment, these are where people say I've got a problem with my thinking or my memory. You can see that there's a steady rise going up to almost 40% in people who are 85 and older, as represented by that orange bar. Okay, next slide. Now, if you match that up with prevalence of objective cognitive impairment, so that would be memory impairment or other domains of cognitive impairment, you can see that there's a little less of a prevalence, but it does march upward as people become 85 and older. So there's kind of a steady state between 65 and 84-year-olds, represented by that light green and buttercup, I guess, yellow bars. So the take-home message is that early in aging, 1 out of 5 individuals will have some type of objective cognitive impairment. And then as you get to the oldest old, you'll have up to 1 out of 4 that have some evidence of objective cognitive impairment. So these are not small numbers, and that's why we always recommend screening older adults for memory, or at least certainly asking them about memory issues. So as it turns out, the U.S. Preventive Task Force recommends that people or the clinicians ask the patients if they have any memory issues, and if they do, then to go on to do screening tests that we'll talk about. From a geriatrician's perspective, we like to routinely screen for memory issues, both by asking the patient, and then also asking the spouse or caregiver, and then to do some evidence-based tool, such as using the mini-cog test would be a good one in the outpatient care setting. Okay, next slide, please. So overall, we have a range of prevalence for mild cognitive impairment. And you can see that the numbers are a little higher when you ask people for their opinion as to whether they think they have cognitive issues. And then when there's actual formal testing, that number is a little less. And importantly, there's no gender preference for mild cognitive impairment. However, in terms of race and ethnicity, African Americans tend to have about a 5% higher incident rate per age group. And also diabetics seem to be more predisposed to mild cognitive impairment than other chronic conditions. Okay, next slide, please. So the important point of this slide is that in the middle is minimum or mild cognitive impairment, and it can progress to dementia. However, not all people with mild cognitive impairment progress to dementia, and in some cases it actually goes back to normal aging cognition. And there was a wonderful study done by Linda Fried when she was at Johns Hopkins, and she basically asked the question is, if I have older adults, and this is focused on the women's health study, who are over the age of 65 and demonstrated evidence of mild cognitive impairment, if we engage them in the community with volunteerism, primarily reading books to grade school and elementary school age children, would that alter their cognitive status over time? And amazingly, over 90% of those enrollees in that study had improved cognitive function, so they no longer were diagnosed with mild cognitive impairment. So social engagement was the conclusion, in order to activate the brain and to move from more towards that yellow arrow of moving mild cognitive impairment into the normal range. So bottom line is that minimum or mild cognitive impairment is reversible, and we'll talk about some things that we can do to that may work and some things that may not work so well. Okay, next slide, please. So you might ask that if you diagnose mild cognitive impairment, what is the rate of its progression to dementia? And generally studies suggest about 1 out of 10 will convert per year, with a total conversion of up to 15 to 16% in the first 2 to 3 years. It tends to be a steady beat upwards with the conversion that can to dementia that can occur anywhere from a 1-year time period to up to 8 years and maybe even more. So people can languish with mild cognitive impairment for many, many years, so it's somewhat stable. So nobody really knows what the trajectory is, although there are some indications that we can diagnostically identify people who are likely to progress to dementia based upon some of our cognitive testing and also our diagnostics. So the important point is that if you look at a 4-year period, or I mean a 5-year period, the conversion to dementia will occur within the first 2 to 3 years. And so that's an important consideration when you're discussing with the patient and family about what their prognosis may be. And that's a critical time with which we want to implement key elements, for intervening in preventing cognition from deteriorating further. Okay, so next one, we can see here that there really is a continuum of normative aging. So generally, we don't think of aging as a disease. There are some slight cognitive changes that do occur with normal aging. It may take a little bit longer to acquire memory The memory may not be sustained as long. Learning strategies tend to be a little bit different as people get older. However, the actual progression from a preclinical phase into mild cognitive impairment involves, again, this duality of objective and subjective impressions of impaired cognition, but yet there's preservation. They're able to do everything that they're capable of doing everything in their usual activities of daily living, which, if it progresses to dementia, then those functional domains, so certainly in instrumental domains, those would be finances, transportation, shopping, meal preparation. Those would be the instrumentals. And then in the activities of daily living would be things like grooming, bathing, dressing. And of course, on top of that is this unifying theme of generally forgetfulness. Okay, so next slide, please. All right, so mild cognitive impairment is not one disease, it's a syndrome, it's heterogeneous, and you can see the different types of dementia here that it might lead to. So certainly the most prevalent one is Alzheimer's, but you can see all the different subtypes there that are related to Parkinson's disease. A subset of that is Lewy body dementia, and these circles don't necessarily represent the proportionality. They're just, the different types of syndromes that you see that are, so for example, Alzheimer's disease mostly presents itself as cognitive problems such as memory loss, whereas on the right side, those dementia conditions typically present themselves with physical changes such as Parkinson's disease having that cogwheel rigidity. Okay, so the next slide, please. So, as inferred from our pretest questions, age is one of the factors that's related as a risk factor for converting cognitive impairment, mild cognitive impairment to dementia. There are some abnormal neuropsychiatric syndromes that can be identified, and that's why we use neuropsychiatric testing extensively in the workup of mild cognitive impairment. So there may be delayed verbal recall, problems with visual recognition, and then of course some very subtle instrumental activities deficits. Interestingly, there is a program for visual speed processing that has been linked to cognitive impairment. And we're actually at University of North Dakota, we're investigating getting this as one of our home-based telehealth processes for screening for impairment. And the idea is that you get a flash of a figure, and it's your response time to when you identify that. The speed with which you do that is directly linked to cognitive functionality or conversely disability. Okay, next slide, please. There are some psychological predictors of MCI, and so the range is depression, apathy, anxiety, and dysphoria. There's no evidence, as far as I can tell, where aggravated grief leads to MCI, but those are always concerns that when somebody has a stressor in their life, that the stressor itself can lead to cognitive changes. I often cite a very early study in where scientists looked at stressed out rats, and they were put on a water platform or a little island in the middle of the water, and he stressed them out by giving a small electric shock so they'd have to jump into the water. And these rodents hate water, so they were really stressed out. And what he found over time is that they had high levels of cortisol circulating in their system, and they had brain atrophy as a result of that. And so chronic stress and these psychological elements can definitely contribute over the long run to decreasing cognitive function. Okay, next slide, please. So this might be of interest to folks. It's one of the reasons why I talk about measuring gait speed as such an important clinical parameter, because it also, slow gait speed predicts falls, but it also is a predictor of future cognitive impairment. And so there's an investigator from New York City who is a neurologist who coined the term motoric cognitive risk. So this is this motor deficit and cognitive deficit. And he feels that it exists in about 10% of the population, where you have this slowness associated with cognitive slowness. So physical slowness and cognitive slowness. Generally, if your gait speed is less than 0.8 meters per second, that would be a high risk for both falls and for future cognitive impairment. So that's why we try to incorporate in our clinic gait speed as a key measure. Okay. So you may have heard about this olfactory dysfunction. There are some studies such as the brief smell identification test, and people that performed in the lower quartiles for smell recognition were generally identified as individuals who might progress to either to minimum mild cognitive impairment, so they had a twofold increase in that transition, or they would also transition from minimum or mild cognitive impairment to dementia. Okay, so if you lose your sense of smell, that's one of the things that people don't always understand in long-term care facilities. They say, oh, everything smells of urine. This must be terrible for the residents. And, in a memory unit, folks who have memory loss can't smell. So it really is not as big of an issue, but nonetheless, it's an important illustration that your senses decline, both visually, hearing, and smell. And I also point out that improving hearing in a cognitively impaired patient can actually elevate their cognitive score by 1 full point on the mini mental status exam. So always looking in somebody's ear for cerumen impaction is as valuable in the regular population as it is in the, and even more so in the dementia population. Okay, next slide, please. All right, so what kinds of things help us identify mild cognitive impairment, and also what helps us identify those who will convert to dementia versus a smaller but significant portion who never progress to dementia? Okay, so the next slide, please. So you might ask about genetics, and so the ApoE4 alleles have been linked to an increased risk for dementia, but does not guarantee that those people will get dementia. But it turns out that there's absolutely no evidence that having the ApoE4 has any significance for converting from mild cognitive impairment to dementia. Nonetheless, the idea that ApoE4 is one of those proteins that hold on to cholesterol very tightly, and that cholesterol can be toxic to brain tissue. Every effort should be made to try and reduce cholesterol levels in all people, as well as especially those with ApoE4 genotypes. Okay, next slide, please. So what about chronic diseases? Well, metabolic syndrome, obesity has a hazards ratio of 4.25, so that's pretty high for linkages to both mild cognitive impairment and conversion to dementia. Whether that's due to lipid disorders or glucose disorders, it's generally a metabolic issue that has global negative effects, and that's why, for instance, in the diabetics, that they have a high hazards ratio too. because the uncontrolled sugars cross-link with proteins and cause these aggregates that lead to increase what we think to be proteotoxicity, or toxic proteins that accumulate in the body. Next slide, please. So people have looked at markers, so the cerebral spinal fluid. There is some evidence that if you have elevated tau protein or a specific phosphorylated tau protein called threonine 181, that's associated with the conversion of MCI to dementia. Also, people find low amyloid beta, the small amyloid peptide, and people ask, well, wait a minute, I thought Alzheimer's patients have high levels of amyloid beta, and the answer is yes. In the tissue, they have high levels, but in the serum, plasma, or cerebral spinal fluid, they tend to have low levels. And so the idea is that there's this kind of excretion of these amyloid proteins that get sopped up like a sponge in the brain, in brain tissue. Next slide, please. So really the big question for a lot of us is what kind of neuroimaging works best in detecting mild cognitive impairment or associating with that. So bottom line is that we have functional assays where we have functional MRI or PET scans, and then we also have structural MRIs and CAT scans. So next slide. So I think probably the prevalent thinking is that if you find either hippocampal or temporal lobe atrophy, and you can see a series there of 4 different patients where if you look at the arrows, you can start seeing differences where as you progress from left to right, there's increasing black space, which and decreasing white enhancement. These are all indicators of atrophy. And it turns out that a study like this was done in Europe, and they found that people who were on the Mediterranean diet had brains that looked more like the scan on the left, and that people who were on a non-Mediterranean diet, so mostly meat eaters, had brains scans that were closer to the 3rd and 4th panel on the right. So they linked nutrition to brain atrophy, which I found intriguing. And this was over a very short period of time of 5 years. Kind of just, you know, word to caution about how nutrition can affect brain atrophy. And I would also point out that brain atrophy itself is not predictive of cognitive impairment. It's perhaps maybe the change over time that is predictive, but not seeing it on a one-time scan. Okay, next slide, please. So we have other scans such as the PET scan with the glucose distribution. And we also have functional MRI to look at areas of the brain that have what we call hypometabolism. So less circulation or less metabolism of glucose and other nutrients. So the PET scan showed when combined with psychologic testing was highly predictive of a conversion rate. So the point being here is that you can use a PET scan, but you need to couple it with psychological testing, psychometric testing, to really have any type of power in terms of identifying people who have MCI and may convert to dementia. The amyloid and now the new tau PET scans are still somewhat in that, what do I call, experimental modes. They're not routinely available. You have to go to large medical centers with Alzheimer's centers to get the amyloid PET scans. But the point there is that the amyloid load doesn't always predict Alzheimer's, but it seems that if the tracer is retained on the brain scan for longer periods of time, that might be predictive. Okay, next slide. So what about the diagnostic workup? So firstly, you want to look for reversible causes of cognitive dysfunction. And certainly medication side effects are high on the list. I have a colleague in Fort Worth, Texas, who was taking care of one of the wealthy matriarchs of Fort Worth, and she thought the 98-year-old was close to her end of life, and she says, well, maybe we should get rid of some of these medications. They don't seem to be doing much good. After which the patient woke up and asked which one of her doggone kids would have given her all those drugs to try and get their last will and testament settled before too long. So she was not too happy with her family for putting her on all these medications. And good example of people who literally wake up when you get rid of some of these medications with cognitive side effects. And just as a caveat or sideline to that is that medications with high anticholinergic effects tend to be the ones that affect the brain most commonly, but others that have amnesia effects, such as lorazepam and the benzodiazepines, these are all important considerations, and of course long-term opioid use. So I've actually used that observation that long-term opioid use causes Alzheimer's, and you'd be amazed at how many of my older patients jettison their nighttime tramadol with that information. Always need to think about obstructive sleep apnea, so doing sleep studies. We need to screen for depression. Sometimes people say depression is the precursor to Alzheimer's, but not always. And we continue to look for B12 deficiency. I'm of the camp or belief that if you're in the lower quartile of normal B12 deficiency, that it's beneficial to ramp up serum levels to mid to high to optimize the B12 effect. And then hypothyroidism. And this is hypothyroidism, probably a topic for a whole new discussion, because there are people who have marginally elevated TSHs that might be 4 or 5 level on testing. And those people typically do not have hypothyroidism, but they're compensating for producing some thyroid hormone that is been sugar-coated, if you will, glycosylated, and is not as potent. And so the body naturally starts to produce more TSH to get more of the good T3, T4 produced. Okay, next slide, please. Well, in terms of treatment, I think I mentioned earlier that we want to aggressively treat cardiovascular risk factors, because anywhere from a third to half of Alzheimer's patients also have overlapping cardiovascular problems, so microbrain infarcts, ischemia, and so forth. Want to call your attention to the SPRINT trial for treatment of hypertension in older adults, which actually has a target of 120 systolic, which shocked the daylights out of all us geriatricians. We all thought, hey, if you're around 140, that's good enough. In fact, even some of us would be okay with up to 160. However, the SPRINT trial really shows that you can improve life expectancy by 3 years. You can reduce strokes substantially through very aggressive blood pressure treatment. And then likewise, cholesterol management, either through a combination of diet or statins. And I want to mention that there was some controversy a few years back where people thought that the use of statins caused problems in cognition, in particular learning ability, and that observation and theory has since been debunked. So there's no evidence really supporting statins as being detrimental to cognitive function long term. Next slide, please. So I mentioned about diet, and the verdict is still out, in terms of whether You can prevent mild cognitive impairment or dementia with either the Mediterranean or MIND diet. There's are other diets. The MIND diet sort of supplements the Mediterranean diet with a lot more fish, and so omega oils. And I will say that if you take fish oil, that does not prevent MCI. It doesn't do much of anything. It's sort of like they're finding with the probiotics. They're not really doing much of anything either in terms of overall health. So more placebo than anything else. But it would be true to say that there are some nutritional evidence in epidemiologic studies. So for instance, I'll talk a little bit about this later, but Asian Indian diets that are high in turmeric tend to have a lower incidence and prevalence of Alzheimer's disease, thus suggesting that the spiced turmeric might have some sort of protective effects because it is anti-inflammatory, and there is an inflammatory model or theory behind why we get Alzheimer's disease. In terms of physical activity, so people who already have established diagnosis of mild cognitive impairment will gain 1 point on their cognitive exam after a 12 to 16 week aerobic exercise program. The big issue there is maintenance, and so once these people go through these group exercise programs, they tend to not adhere to their exercise program thereafter. It's also been clear that cognitive training programs are helpful. These are, some of them are computer-based, some of them are games, and there's a bunch of proprietary products out in the field, none of which I have much knowledge about, other than they stimulate the brain, and that's important. So they probably are all good. I don't have any evidence that one's better than the other. Next slide, please. Yeah, so the other point of treatment with this contemplative older fellow walking down the road here is dual task training. So it is true that people with, well, all people, but particularly those with cognitive impairment have an increase, at least a twofold increased risk of falls. And one way to prevent future falls is to increase their postural stability by basically disconnecting the upper brain from the brain stem. And you do that by having people walk and do some sort of mathematical gymnastics. And so they maybe subtract 3 from 100 and keep going, or they may add 2 to 1 and keep going up to 100. So they can change it up. It doesn't matter what their mental math, or they can even say the alphabet. The idea is that you're activating the brain, and it's disconnecting itself from the cerebellum and the brainstem, which then has to take over for balance. Because as it turns out, studies show that as we get older, the cortex, the cortical part of the brain, tends to compensate for age-dependent laziness of the spinal cord to keep us on balance. So don't know the exact mechanism of that, but it's an important intervention for improving postural stability. And of course, things like core training, so where people have balance testing with their ankles is important. Yeah, you can go to the next slide. Thank you. So not recommended, and this is part of the American Academy of Neurologists. So do not give acetylcholinesterase inhibitors. It really has no impact on the conversion of mild cognitive impairment to Alzheimer's. Less certain is prescribing Namenda as a neuroprotectant, but a lot of times you'll put people on rivastigmine or Aricept, and you find that they start losing weight, and guess what? It's causing a gastritis, and they have GI upset. So a lot of problems with those medications, and they don't really have a huge impact on dementia anyways. So it turns out that there was a study by John Breitner from Duke, actually I was there at the time when he got this study, that found that twins, identical twins, one who took chronic Motrin or aspirin for arthritic problems, had a lower risk of Alzheimer's disease, lifetime risk of Alzheimer's disease. But they've not been able to replicate that study prospectively. I mean, there's theories that anti-inflammatory medications would be able to reduce the inflammatory mechanism of Alzheimer's, but the COX-2 inhibitor, rofecoxib, did not have any impact on mild cognitive impairment patients. So it remains to be seen as to whether these classes of drugs have any impact. Certainly, steroids have no impact, if not an accelerant to memory loss. Okay, next slide, please. Yeah, so people always come into my clinic, they're on ginkgo biloba. Randomized controlled trials are pretty strongly show no benefit. You know, the glucosamine chondroitin sulfate glucosamine similarly doesn't show any benefit for osteoarthritic. So, you know, a lot of these supplements not doing what they're advertised. Phospholipids, so people get phosphoserine or lipid mixtures. Can't really say one way or the next. So a lot of small studies. Some say they work, some say they don't. It's been around for at least 40 years. It has not cured Alzheimer's. Mentioned also about the fish oils. So the omega oils have no effect on preventing MCI going to dementia. There's one early report about high-dose vitamin B complex being effective, but follow-up studies did not really confirm that. Okay, next slide, please. So just a few more recent studies. People are looking at treating hyperglycemia. So different ways of doing that. One is this intranasal insulin study for amnestic mild cognitive impairment. Another promising study is growth hormone release hormone. So not growth hormone per se, but rather the releasing hormone. And then I mentioned about curcumin, which is turmeric, as you see on the right. I'm trying to grow my own batch of turmeric here in North Dakota, and I have to tell you, it's not going too well. Turmeric likes really, really hot weather, and I guess my pre-planting in the winter didn't work out so good. But anyways, that aside, what they find is that for those that are cognitively intact, turmeric has been found to be beneficial in preserving verbal memory, visual memory, and then also attention span. There are a lot of negative studies, I have to say. So, in fair and balanced representation, I think part of the problem is how much turmeric you're supposed to take and for how long. And I'll just point out that the minimum amount for a anti-inflammatory effect is 1.5 grams a day, as best I can tell from the literature. And so if people are interested in taking turmeric, I recommend 2 pills of 500 milligrams in the morning and 2 pills in the evening. So that would give them a total of 2 grams or 2,000 milligrams of turmeric. Okay, next slide. Yeah, so we talked a little bit about the stages of dementia. I don't want to really, that'll be a presentation for another time. And I think that may be the last slide there. One more, maybe. Yeah, so I just want to close with this slide. So this shows a trajectory. This is an artist of fairly modern times here that shows that with each consecutive year, how his sense of visual spatial changes occurred over time, and it really got distorted. So a key point that we need to remember from this illustration is that older adults don't always see things the way we see them, okay? And so that's why in the treatment of patients with Alzheimer's disease that you be very cautious with what kind of nonverbal language you provide. And so the angry eye, the furrowed eye might be interpreted as aggression as opposed to the raised eyebrow. The smile may be interpreted more benignly than the frown. And so everything gets exaggerated and distorted. And I always think we have to remember this, that even in periods with dementia where there's aggravation and agitation, that we still maintain on our end as the providers and caregivers, the more disarming visual appearance, to help them get through that moment. So with that, I'll open it up to questions. Just mentioning here, we want to work towards an age-friendly and dementia-friendly communities, both in the hospitals and in the community at large. So I'd like to open up to questions if anybody has any questions about the talk or particular cases that they might have that concern them.
We do have a question in the chat box from Nancy. Can dementia occur without MCI?
Yes, and so I think it's a matter of how you catch as catch can. Yeah, you can see somebody clinically who has dementia, over time, and you may have missed the window. So importantly, I think the studies on the demographics and prevalence of MCI suggest that there's about a 2 to 3 year window that people progress from cognitive changes. And quite honestly, a lot of people don't like to admit that they're having cognitive problems, because they're fearful or they're not sure that it's really real. And so I think we underdiagnose MCI. And as you can tell from those prevalence studies, it ranges from 1 out of 5 to 1 out of 4 for older adult population. So it's out there. And if we're testing it, we're gonna find it. And I think from my perspective that it's an opportunity then to become more aggressive and to hit the point of trying to prevent it from going towards dementia. That said, one of my first weeks here at Sanford Health, I thought I was going to be a very good geriatrician, and I was screening everybody with cognitive testing. And one of my patients just got furious. She says, I came into the clinic for hip pain, and that Dr. Jurivich was testing my brains. I don't understand what's going on. And so, for those that are familiar with Press-Ganey reports, I got a miserable score on my Press-Ganey because customer satisfaction was not, or patient satisfaction was not too good for me because I was testing their memories. So these good Norwegian women don't like their brains tested.
Okay, we have another question in the chat. If patients are taking turmeric, how concerned do we need to be for them developing iron deficiency anemia?
Well, I'm not so sure that there is a strong relationship between turmeric intake. I mean, it would be true of if they were a vegetarian, that you'd worry about iron deficiency. And of course, iron deficiency predisposes to blood clots. And so you always want to be mindful of iron levels. And then conversely, you want to be mindful of not overexposing people to things. And I think the big concern about general turmeric supplies is that there's been reports that they may have high levels of lead. So somebody that's on high levels of turmeric, I probably would get a lead testing down the road, just to be sure. But and in general, anybody that's on supplements, either regular or high dose, I think it's always good to get serum chemistries and blood counts and urine just to monitor that they're not having any end organ damage. And I often tell people, I said, they use herbals quite a bit in China. They're very, very popular, but the people that die the fastest and earliest are the herbalists in China because they get toxic from the things that they're taking herbally. So again, always a word of caution.
Okay, here's another one for you, Dr. Jurivich. What level of B12 do you target with supplementation?
Well, Again, it depends on the lab parameters, but we want to go anywhere above the lower quartile, if that makes sense. So if you have 400, it's usually around 400. I think nanograms. I'm not sure the exact value, to around 800. So you want to be around that 500 to 600 range, at least for our laboratory purposes. But look at what the normative range is, and we'd like to push it, towards normal. And a similar argument is made for vitamin D, so that when you get above a blood level of 40, it tends to become more anti-inflammatory. So some people will actually push higher levels of vitamin D for both osteoporosis and for improving immune system and brain function.
Okay, does anybody have any other questions? Feel free to either unmute and ask or go ahead and put them in the chat. And then just to remind you, Dr. Jurivich, we do have the 3 remaining poll questions whenever you're ready.
Good, yeah, so we got 5 minutes. Let's